before y'all destroy me. Okay, we're gonna talk about peritoneal dialysis. Where's your peritoneal cavity?
Oh God. You have to like all over.
Okay, so like where the abdomen is, but outside the organs.
Yeah.
Was it y'all's class that somebody said perineal and I could have died? I was like, no, we don't do dialysis in your TT. Okay.
No,
Who was it, y'all's?
us.
No, it's a different class. Okay.
Okay.
Yeah, she's like, oh, that's probably me. Okay, so peritoneal dialysis. So we are going to remove all the waste products, the electrolytes, remove everything from the patient's blood. We have two ways we can do that. We can either do it by osmosis, which sounds so scientific, or we can just take out all their blood, clean it, and give it back to them. Okay, so you've got peritoneal and you've got hemo.
Okay.
Got it? We're going to start out with peritoneal. Now the patient, Abby, is going to be in the hospital for this. Now, some patients, they will teach how to do peritoneal dialysis on their own at nighttime. It's just really dangerous. You got to be really careful. Yeah. But most of the time, if this is an ICU and it's an acute situation, so that means a patient had an AKI, we're like, oh shit. And they're in ICU, right? And then they're like, we need to do dialysis. We need to do it immediately. We don't have time or energy for hemo. So we're just going to do peritoneal. Okay, so what is peritoneal dialysis? We are cleansing their blood of all kinds of junk. Yeah, because now we know all the junk that's in it.
Yeah.
Okay, these could be patients with AKI, which is acute kidney injury, with CKD, chronic kidney disease, ESRD, end-stage renal disease, and RF, renal failure. Okay, so it is going to remove all the fluid, or move fluid from the patient to a bag, and we use hyperosmolar glucose because what likes sugar?
Yeast.
Okay, that is true. We hopefully will not have that happen. What follows sugar? Water, right? She's all yeast. See, y'all keep talking about TTs and I don't know why. Okay, so water will follow salt. It will also follow sugar. In this case, we're going to give them a high sugar concentration inside the peritoneal cavity. This is not going in their blood. You'll understand that. This is not hemo. Okay, it can also pull out all the acid. It pulls out all their waste. And it pulls out all their extra electrolytes. Isn't that so nice? Okay. So we usually will do peritoneal dialysis once their GFR is less than 15. I mean, that's bad. Kidneys are not doing good. Okay. So you can see right here, they have this dialysis solution. They will call it the dialysate. Okay. It is mostly made up of
Water.
I already told y'all it was freaking sugar. I just said it. Okay.
Dialysate.
Okay, so the dialysate has a lot of sugar. It also has other electrolytes and molecules that are able to pull fluid from your patient. Are you with? Okay, we are going to actually put a hole in the patient's abdomen. So they will have to go into surgery. We don't just be like, good luck, So they'll go into surgery. We make a hole below their belly button, usually. Okay, and that is going to be the hole at which we can put the catheter through. And it just stays that way. Okay.
Okay.
But we have to, once they get the surgery, you obviously can't use it immediately because it's a giant bloody hole. No, do you understand what I'm saying? Okay. So after they get it, and they get that hole put in for 7 to 10 days, you can't change the bandage because you obviously don't want shit leaking from their peritoneal cavity, right? So you need to keep the site dry. They can't bathe, they can't shower, they can't swim because it's just a hole directly into your peritoneal cavity.
How big's the hole?
It's like this big. Okay. They cannot do any heavy lifting. If they lift something heavy, what do you think might happen? What comes out?
All the junk, like all the blood and
But
stuff.
what?
What do you mean? What?
I'm asking you if the catheter is not in there right now. So
Like intestines?
yeah, their intestines will come out
Oh.
of the hole, right? Because it's a hole into the peritoneal cavity, right? Y'all understand it does not go into the intestines. It's not a colostomy. Do you understand what I'm saying?
Yeah, isn't that called something else too? If you have like a hole in your intestine.
Oh, you're thinking of a hernia, except for that usually the skin is covering it, but in this case, you don't have any skin. A hernia is when the intestines
like after surgery.
Dehiscence?
Yeah.
Oh yeah, that's gross. Evisceration is probably what you're thinking of. Yeah, we don't want that. Okay. We will definitely give them a stool softener after surgery, right? Because we don't want them being very constipated. We need stuff to move. Yeah. Okay. So that is how they get the hole there for peritoneal dialysis. Are y'all with me?
Yeah.
Okay. Then once it has healed, okay, and it is ready to use, because you can't use a bloody hole. That would be terrible for your patient, right? Okay. Yeah, I know that's gross the way I said it. So pre-dialysis nursing care. So if I know today is dialysis day, okay, I'm going to do a full set of vitals because tell me some complications that we may see from pulling out a ton of fluid and electrolytes off a patient at one time. So hypotension, right? So our electrolytes can go low, right? So there's a lot of changing fluids. We need to watch fluid and electrolytes very closely. But what happens if it's peritoneal dialysis day and I go to take my patient's blood pressure and it's 90/60?
That's bad.
Okay, so I wouldn't want to do that because I'd pull too much fluid and I'd cause them to go into shock and then give them an AKI. And that's the whole reason why we hear I don't want that, right? So what would I do for that patient if they were 90/60 and it was dialysis day? We're going to give them fluids first, and then we would go in and do dialysis. Now, it doesn't happen very often because usually they have too much fluid, right? But sometimes when they third space, we may see a blood pressure changes, right? So that's why you need to take a full set of vitals, and you have to take orthostatic blood pressures, which means you need to take 4 extremity when they're laying down, sitting up, and standing. Yeah.
Yeah.
All right. I definitely need a weight. Why would I take their weight right before dialysis? I need to know how much I got off of it. So I'm going to weigh them right afterwards as well. Right. I need to auscultate for crackles. That's very important with our CKD patients. Now I will report that, but dialysis might fix that, right? Because it's going to pull off some of the fluid. Yeah. We're going to look for JVD. Again, not going to tell me not to do dialysis. I'm just going to look and see if it improves for afterwards. Yeah. All right. So labs, I need to draw labs before I give them peritoneal dialysis. What do you want to draw? What were your biggest worries? We can draw BUN and creatinine, but yeah, okay, we can do that. Then I can look and see what it is afterwards. Sure, I could do that. But what were your biggest complications? Electrolytes is a big one, right? We also need to do a CBC because aren't these patients at high risk of infection? If I get their CBC back and their white blood cell count is 25,000, do I want to do dialysis today? No, because it means I have an infection and I need to look and find out where that's at before I start mixing fluids. You understand?
Yeah.
Okay. I'm also going to measure their, I hate that word, but yes, we're going to measure their abdominal girth and then I'm going to measure it afterwards and see if this got any better. Yeah. You have to have the patient pee. How come? Have them pee before you start dialysis.
Hit their bladder?
Yeah, you could hit their bladder. And also they're going to be laying down in that one position for a very long time and they can't get up and run around. Right. So if they have to pee, now is the time. Yeah. And the hole is actually pretty close to where the bladder is. So probably best to have them have an empty bladder. Yeah. And I can also get an accurate blood pressure because if they don't pee, it can raise your blood. Yeah. Okay. All right. Make sure that you warm the dialysate to room temp or body temp. If you try to give them cold dialysate into their peritoneal cavity, what's going to happen to your patient? Anytime you put cold fluids into someone that like, okay, from first semester, do you remember what they told you about eardrops and why you don't put them in cold in your patient? Nope, that didn't help you. Okay.
I don't remember talking about that.
Well, that's an important concept. Okay. So what does cold do to your vessels?
I was going to say,
Okay. So vasoconstricts, but it'll also make them vomit. Anytime you put, that's why you don't put cold drops in someone's ear, they'll puke, right? So anything that's super cold, your body does not like that, right? Y'all probably heard of people, like I saw this roaming around on TikTok where some dude like worked outside and it was super hot and then he went and drank ice cold water and passed out, like it vasoconstricts too fast. Okay. So you want to make sure that it's a room temperature or body temperature. If you see that the dialysate is cloudy, we have some probably yeast, some kind of bacteria growing in the bag and you don't want to put that in someone's peritoneal cavity. What is the big red flag sign and symptom that I would report if I'm doing peritoneal dialysis on a patient? Rigid bore-like abdomen, because that means they have peritonitis. Okay. You need to also look at the access site before you access it. If it looks infected, you're not going to infuse anything through it because you're going to give them peritonitis, right? So when you're doing peritoneal dialysis, this is a one-on-one. Okay. I'll be sitting next to you the entire time. Okay. And the doctor will give you orders. Okay. He will say, it almost looks like a recipe when you get it, which is why it's 1-to-1 and you have to sit right next to the patient. Okay. Because they will say, give you an infused time. An infused time is the amount of time you're going to let the dialysate drip into the patient. Then it will give you a dwell time. What's a dwell time? How long you let it sit. And then they will give you a drainage time, but it's not just 1, 1, and 1. Okay. It'll say like infuse for 2 minutes, dwell for 2 minutes, release for 3 minutes, then infuse for 4 minutes. Like you have a whole that you're just sitting there and you're doing eyes and nose rapidly, right? I put in this amount for 4 minutes and this one, and that it takes a lot of work. That's why it's one-on-one. Do you understand? All right. So when you're about to put in the dialysis solution, it has to be sterile technique, all because you're going through a giant hole in their abdomen. Yes. Okay. There will be meds that you can add to the dialysate. So sometimes that may be your responsibility to do that. And you need to prime the tubing. What happens if I don't prime the tubing to do dialysate? You're gonna put a bunch of air in their peritoneal cavity and you'll know that air rises. So those patients are going to start complaining of chest pain, even though it's just gas. Okay. So we're going to prime it with dialysate. You with? All right. You're going to connect it to the insertion site and then you'll understand what infuse time is. That's how long you're going to allow it to infuse into the patient. And then dwell time is how long you let it sit and do its thing. Everything has to be meticulously measured. Are we clear?
Yes.
Okay. Let's say you're doing peritoneal dialysis and all of a sudden the patient says, I can't breathe. What's happened? Oh shit, we done did something wrong. Probably not air, but. Okay, so y'all know the patient's laying like this and you're infusing a bunch of fluid, right? It's pushing on their lungs, right? Okay, so what would you, if they start having respiratory distress, what are you gonna do? What's the first thing you would do? How about we stop the dialysate first? Okay, so we're gonna stop the dialysate and sit them more upright, and then you need to call the physician because something went wrong somewhere. Okay. All right. You need to watch also what is coming out into the drainage bag, right? If it is bloody, what does that tell me you done did? Straight up blood. When you stuck that in, what did you do? You hit the worse.
Worse than bladder?
No, you're down here.
Intestines?
Yes, you bowel perfed them. So now they have blood and poop and waste products all filling up their peritoneal cavity, which you put dialysate in. So now they're rapidly absorbing it. What are you going to cause to have this patient? What will happen? Peritonitis, massive hemorrhage, and sepsis. Oops. Weren't supposed to do that. All right. So that's important. If you look at the dialysate that's coming out, the drainage, and it is super cloudy, what does that tell you? They have a bacteria in there. So they probably have peritonitis and that needs to be reported immediately. Do you understand?
Yeah.
Okay. So there are 3 different phases. We do the inflow, right? The dwell, and then the drain. Yeah. If it's not draining super well, what can you do? We just need it to drain. You could change positions of the patient, or you can just do like a tiny little abdomen massage to be like, get out of there, you dialysate. You understand? Okay. Post-dialysis care. So we finished the dialysis. They drain. I don't know why I am this way. They drained out. Okay. What do we need to do afterwards to see, did this work? Wait.
Check levels?
What levels? Electrolytes, uric acid, all those waste products we were trying to get out. And no.
ABG.
Okay. Yeah, that's fun. Okay. And then you said abdominal girth, and that will tell us, did this work or not? But what is the number one assessment you probably ought to check right afterwards to make sure we didn't kill them? Blood pressure. Because if you took off all that fluid and then you check their blood pressure and it's 88/40, you're like, oops, I'm sorry. We done drained you dry, you know? Okay. Do you understand?
Yes.
All right. So complications. Let's say you did peritoneal dialysis a couple of hours ago, and all of a sudden the patient's like, my abdomen really hurts. And you go and assess it and it is hard as a rock. Oh, you need to report that immediately. That is a sign of peritonitis. That's bad. Okay. Fluid imbalance, hypertension. And then remember, peritoneal dialysis causes massive protein loss. So what do you need to do for a patient on peritoneal dialysis? Yes, albumin levels, but they need to go, we need to increase, you're right, but we also need to increase the protein in their diet. Do you understand peritoneal dialysis? Yes. Okay, let's do hemodialysis. Okay, so hemodialysis, where we take out all the blood and then give it back to them clean. Yeah, okay. Okay, so the dialysate in this case, remember peritoneal dialysis, what was the dialysate made out of? Mostly sugar, right? Which is why infection, big deal. Yes. Okay. In this case, it's made out of water. They also put potassium, sodium, calcium, mag, chloride, and some dextrose, because, and the reason why we're putting it in there, it's not to give it to your patient, because we're obviously high in most of those. Those electrolytes can help pull out other electrolytes. Okay. So we're playing the seesaw game here. You with?
Yeah.
Okay. And then they usually will add bicarb to it because most of our CKD patients are in acidosis. Okay. Now remember, these hemodialysis machines are used by everyone, and your blood's going through the same machine as everybody else. So you do have a risk of HIV and hepatitis when you're on dialysis. They clean them. I mean, obviously, but like you have to tell your patient that. Okay. All right. So they have to do this 3 times a week for the rest of their life.
Wow.
Yeah, it's awful. So access options, we obviously need a giant ass needle because you're going to drain out all of their blood, right? And that would take a very long time if you used a tiny venipuncture needle. So we need a big one. But if they're getting this done 3 times a week, you're going to run out of vessels, right? So your access options would be a CVC, which is a central venous catheter. We don't prefer these for hemodialysis for these patients because the risk of infection is so high, but it is an option. Okay. Our better option would be an AV fistula or an AV graft. Okay. What does the AV stand for?
Arteriovenous.
Arteriovenous. So we want the flow of arterial blood without the risk of a bleed. Do you see what I mean? Because I can't just start like an art line in this patient and send them home. Because what happens if it comes out? They'll bleed to death and die. Yeah. So we don't want that. So we want the flow of an artery with the access of a vein. Good. So let me show you what that looks like. Okay.
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 I felt one the other day.
Oh, you did?
Yeah.
That's cool. All right. So we're going to do a graft where we're taking a vessel either from the patient or from, what's going on? Or from a different patient. Okay. So here you have a vein. Bear with me. Okay. And then you're going to have an artery next to it like this. Okay. And we're going to graft. So the AV graft, I take a vessel from another part of the patient's body and we're going to put it in between these. Okay. So this is artery and this is vein. Okay. So then, when we access this, I can access their vein, right? So I'm going to put a catheter in right here. You with me? Okay. Well, when I put the catheter in and I pull back, it's actually going to be pulling arterial blood, but I can access a vein. Do you understand that?
Yeah.
Okay. So you understand why we do this is the graft, and this also called a fistula. A fistula just means an opening between 2 things, right? So we're opening between the artery and the vein. Do you understand?
Yeah.
Okay. So very, very important. Hang on to that for right now. Okay. So who needs hemodialysis? Like this is a big deal.
Like in stage.
Like end stage, right? So ESRD, GFR of less than 15. Though GFR of less than 15 is dialysis dependent. Are we clear? Yes?
Yes.
Okay. All right. So before they go into dialysis or before we start dialysis, what are your biggest issues you're already like anticipating? Because you're about to take out all their blood and give it back to them. So, you know, so electrolytes, infection, fluid is a big one, right? Because they can get hypovolemic. Yes.
Yeah.
Okay. So keeping all those things in mind, now we need to do our pre-dialysis nursing care. So you have to have an order. You can't just be like, well, looks like dialysis is needed today. So you have to have an order. Okay. You're going to assess for all the fluid volume overload symptoms like JVD and crackles and heart failure, all these things, right? So I can see, did I make them better afterwards? You with? Okay. What am I going to draw before they go into dialysis? CBC, because if they have an active infection, I can't do dialysis, right? Because you don't want to pull all their infected blood out and it doesn't pull out infection. It doesn't work that way. So you just infected the machine, right? And then you're also going to give the patient sepsis because you're basically just rotating their, yeah. So don't do that. Okay. So go on. Labs. You said CBC. Huh? Yeah, we can run ABGs. If they don't have an artery, we can also do VBGs. I know venous blood gases we can do as well. Just the values are different. That was new information. Okay. Yeah. There's something called a VBG. So if we don't have an artery that we can pull from, which a lot of times you don't, you know, then you can just do a VBG, but the values are different. The pH and all of that is different. So you would have to learn that. We learned that in, we'll learn that in adult 3. Okay. Moving on. So we did electrolytes, a CBC. We probably want to do albumin levels. Yeah, their H and H is in the CBC though. Y'all know that, right?
Yes.
Oh, okay.
CBC,
Yes. You're gonna probably do BUN, creatinine, and GFR so we can see kind of where we're at. Yeah. Okay. I need to take their temperature before I start dialysis, because if they have a fever, are they getting dialysis today? No, we need to treat the infection and then we'll put them on dialysis, which sucks because they're probably going to be more junky with an infection, right?
Mhm.
Yeah. Okay. This is very important and highly testable for all of you. What are y'all doing? Oh, you got a highlighter. Okay. When you do dialysis, it will clean out any meds you have taken out of the dialysis, right? So there are some meds that we are going to hold because it's just going to pull them out through the dialysis. So if the patient is on folic acid, if they are on any hypertension drugs, or they're on any antibiotics, we do not give those before dialysis. We wait until after dialysis and then I will give the meds, which makes sense for hypertension drugs anyway. Okay, if the patient's blood pressure, which is probably high because they're in CKD, is 160 over, I don't know, 90, right? Then you give them antihypertensive drugs. Now it's 120 over 80. Then you put them through dialysis. Yeah, you see what I mean?
Mhm.
So those 3 drug types are the ones that we would hold until afterwards. Okay. Then you need to access their site to make sure their site's ready to go. Okay. Highlight. You are going to palpate for a thrill and auscultate for a bruit if they have an AV fistula. What does this mean? What's a thrill?
That's where you can feel the blood.
What kind of blood?
Arterial.
Arterial blood, because you're palpating through the AV fistula. So I'm going to palpate, and it's basically like a murmur of your arm. It's turbulent blood flow, right? So you'll feel a okay. And then you're going to auscultate for a, and what is a bruit? It's again
The same thing.
a murmur of the peripherals, basically, but you will hear it with your stethoscope. Okay. It is so important to make sure they have access, because if I do not palpate a thrill or I don't auscultate the bruit, I don't know if this is open, and their AV fistula may be the only line they have left to do dialysis. And what happens if I lose that line? You can't help the patient anymore, right? And that is an artery. So what's going to happen below the level of the AV graft? So they'll have a cold, dead arm that we have to hack off now. Yes. Okay. So it is very important in that arm. That arm is golden. You do not touch it. You do not well, other than to palpate. Okay. But you don't mess with it. Okay. We don't do any sticks on that arm other than to stick to go for dialysis. You don't do blood pressure on that arm. This arm is the golden egg. Do you understand? You just, oh, leave it
If they
alone.
get it 3 times a week, you would stick that same spot
3 times a week.
3 times a week.
That's correct.
Nothing will happen to it.
No, because you have graft.
I was just wondering if that vein that the graft is connected to, if it would.
Well, the vein is going to end up being like this big around, so you can't miss.
Oh.
The problem is when people start getting in there and trying to dig around and things like, have you seen what? Let me show you what this looks like. It is incredibly impressive. Please hold. Yeah, like the regular, it doesn't look like a regular vein.
Yeah, I was just wondering if there's any complications for having to continue.
Sure, you could lose a
to-
line, which is why when the patient goes home with an AV graft, you have to teach them how to palpate it multiple times a day. And they need to palpate for a thrill, okay, multiple times a day, because if they don't feel that anymore, then this is what their vein now looks like. You can't miss that, sister. Oh, that's the veins in their arms. You'll see that. Okay. So yeah, you won't miss. But yes, it will eventually become engorged and giant, and eventually you'll lose it. And then by that time, you can't help anymore. Right. What, the fistulas? Oh, I'm sorry to hear that. Okay. So do you understand to palpate for thrill and auscultate for a bruit, and you teach your patient to go home and palpate multiple times a day. Got it? Okay. So now we got them hooked up to the machine. Y'all know you're going to have 2 different ports access, right? One that you're going to pull all the blood out of, and one that you give it back to your patient. You understand? Okay. So the one you're pulling out is higher than the one you're giving back. Otherwise you're going to.
Right.
Okay. You got this. Okay. So the big thing that you have to watch for during dialysis is hypotension, because you're pulling out all their blood. Now it's recycling. So you can't like drain them of all their blood at one time. That would be death, right? That's what morticians do. Okay. But you are like taking out a lot and then recycling it. You understand this, but they can still get very hypotensive. Okay. If they start to complain of muscle cramps, which is very common because your electrolytes are going crazy, okay, slow down the rate of how fast the hemodialysis is going and give them normal saline. Kind of like, you know, when you are exercising and you get cramps, they tell you to drink pickle juice because it's got the salt in it. That's what we're trying to do. Okay. But they may have nausea, vomiting, headache, because that's what happens when you go hypovolemic, right? And when you switch your electrolytes rapidly, they do have an increased risk of bleeding. Why is this?
because you're pulling out a lot of blood.
You are pulling out a lot of blood.
Because it's already like a site that they're using so much that it can get infected and bleed too.
That's true too. The site can bleed. I agree with that. But how would I prevent, since I'm pulling out all this patient's blood, how do I prevent their blood from clotting when it's not inside their body? You don't want to give them clotted blood or you don't kill them.
Would you have to do like heparin?
The machine has heparin added to the dialysate. So now you're giving your patient heparinized blood, which is good because they won't clot, but they could also bleed. Yes?
Yeah.
Okay. Why could they have dysrhythmias during dialysis?
Like this is not an electrolyte thing.
It definitely could be electrolyte things.
This is-
What electrolytes cause you to have dysrhythmias? Potassium and calcium, right? So absolutely it could be from that. Yes? No? It could also be a fluid balancing. Yeah. Because when you go, when your blood pressure goes low, your heart rate goes high, and that can cause atrial dysrhythmias. Yeah. Do we panic about atrial dysrhythmias? No, but we do something. We're like, oh, this is unfortunate. Okay. All right. Something else you have to watch for is something called disequilibrium syndrome. Basically, you shifted the fluid too fast. And guess who doesn't like fast fluid shifting? Your brain. And you will get severe cerebral edema because now you have pulled all that fluid out too quickly. And now it has pulled it out of the cells and into your blood vessels, and you'll get swelling of the brain. That's bad, y'all. Yeah, that's not what I wanted. So if all of a sudden the patient starts puking and they get real restless, y'all know restlessness, always a red flag, right? Okay. And then no big deal. You only have like 2 minutes before you have to realize they have disequilibrium syndrome before they start seizing and go into a coma. So since they have too much fluid on the brain, what drug do I give to pull it down? Mannitol. And then they're going to start freaking the fuck out. So what drug would I give to be like, it's okay. Yeah. We're going to give a PAM. Okay. To calm them down and then be like, I am sorry this has happened to you.
Too, right?
Dialysis? No, like if they're in outpatient dialysis, they could have multiple patients at one time.
So how
They just line them up in chairs.
so how often would you check on your patient?
Check what? No, they'll just have to tell you when they have symptoms.
Okay.
Yeah,
I was
you ain't just sitting
wondering
with the
if they went
patient.
into that, like,
How you would know? They'd start puking. Hopefully you would be able to see that.
yeah.
Oh, all right then.
Worry.
Yeah, no, it's not one-on-one. That would be nice, but no, in these dialysis centers, they have multiple patients. All right. Post-dialysis. So now we're going to do vital signs and we're going to do a weight again to see how much fluid did I pull off this patient. Yes. Make sure they change position slowly because you just rapidly changed all their fluid and electrolytes. Yeah. Yeah. All right. Complications. We already talked about infection. Y'all know they can get sepsis because they're using the same machine as everybody else, which can have bacteria and
Yeah.
muscle cramps. What'd that happen because of? Huh? Could be calcium, could also be sodium does that too, right? This is electrolyte imbalance. Hepatitis. Why might they get hepatitis? Same machine and needles as well. Yes. Okay. AV fistula care. So once you get the graft done, it'll take up to 3 months before you can use it. Cause obviously it's a new graft. It's been sewed into your artery. So probably don't want to mess with it quite yet, right? That needs to heal. It does. So no PIVs, no blood pressure, no sticks in that arm, except for your dialysis sticks. Everyone's like, well, how do you do dialysis? Do you understand what I mean?
Yeah.
Other than that, we don't stick them for anything other than dialysis. Okay. Remember that arm is the golden arm. We have to watch the 5 Ps or the 6 Ps or whatever it is, right?
Yeah.
Because you could lose that arm because it's arterial. Yes. Okay. We are going to palpate a thrill. And who else does that when they go home? The patient. We're going to instruct them to, with clean hands, do it 3 to 4 times daily. And if they don't feel that, what do? Call the physician immediately. Yeah. And we need to auscultate a bruit. When you do an insertion, it needs to be sterile technique. Yes. No, you have to wear full out PPE, right? So the patient, I mean, not the patient. Nope. The nurse will be wearing gown, gloves, goggles, mask, and like you protect this arm at all costs, right? And then we just hold our breath and you insert it. Yes.
Yes.
Got me?
Yes.
Okay. If I look at the site and it is very warm, what would I do? Well, you probably shouldn't have put it in the first place, right? I would be like, well, this is probably infected and that needs to be reported. Yeah, don't start hemodialysis if their arm is swollen and has some drainage, okay? Okay. All right. What else? I was gonna say to brew. I already told you all that. Oh, okay. When you are cleaning the site, it's just as if you were going to insert into or do something for a central line. What do we clean with? For central line and for this?
It's the little
Chlorhexidine.
Yeah.
Yes, yes. All right. So we're going to clean with chlorhexidine. You with?
Yeah.
Okay. Make sure you check their weight after dialysis so I see how we did.
Yeah.
Do we understand dialysis?
Yeah.
Moving on.